Let me start with a short comment to the active surveillance, which Dr. Wu made. Everything is statistically right, but there are enough studies, meanwhile, that the average time which a patient stays under surveillance is approximately 5 years. After that, 50 to 60% of the patient come and ask for treatment somehow because of the psychological burden. I think that we have to take in account when we judge energy, how is the patient compliance over the long time he has to be under the treatment. So thank you. Excuse me. Yeah, again, the reflection in the lay press. Ahmed published Focal Therapy of Localized Unifocal and Multifocal Prostate Cancer, a prospective development study, and the Telegraph in immediately new treatment for prostate cancer gives perfect results for 9 in 10 men research. So that is understandable that the FDA has sometimes little problems to judge between the first publication and the press media. So what is when you take the objective, what is the advantage of focal therapy? It's we can use it in low risk, low volume tumors, and I will show you some results of that. It is good for the erectile function rate, which is up to 90%, has low side effects, it doesn't need TURP, and doesn't exclude a second HIFU or a second kind of treatment. The problem is really the unclear guidelines for follow-up, what should we take, PSA velocity, biopsies, or multiparameter MRT, unclear efficiency in ventral tumors because of the different penetration depths, and is only useful in compliant patients. Now we just want to show you a series of 66 patients which we have done in Munich and their results, and coming back to the judgment, what seems to be as best for the judgment of a successful treatment is the PSA velocity. When you see here, PSA velocity in these patients was 1.29 milliliter per year, and it dropped to 0.12 nanogram. So that was the parameter which was most reliable for judging the success. You see on the side the positive effect on erectile dysfunction, and the side effects were very low. Now we looked in our data collection and found that when we analyzed the patients, we had in our T1 study how many had unilateral and how many had bilateral tumors. Or when you see 2/3 of the patient had unilateral tumors, so they were able to go in principle in a hemiablation study. Catheter time, as you see here, the majority had the catheter after the treatment 1 to 2 days, so that seems very good. And how we can judge this treatment, and I mean, for the precise targeting, the MRI fusion seems to be very successful, but for the ablation efficiency, the contrast enhanced ultrasound, what you see in the upper picture here, it seems to be the most reliable thing. Now, only going through 3-4 studies that above experience about focal HIFU, 42 patients. That was Ahmed as his group. Focal HIFU leads to a low rate of genitourinary side effects and an encouraging rate of early freedom from clinically significant prostate cancer. And a French experience, 71 patients, and as you see here also, only 1 in 10 had any complication, and they were quite successful, at least in these during the short follow-up time. And another French study which also shows that focal therapy, at least for the observation time, could be very successful. Mean follow-up was 27 months, so it's not too short. And in regard to continence and erectile function, this was a very successful study. Even focal cell could used as salvage therapy after radiation failures. And the conclusion again of Ahmed and his group, focal salvage therapy is a potential strategy for localized recurrency after radiotherapy that may reduce the harms resulting from whole gland salvage therapy. And you see he had a success rate of 69%. And Norwegian and French combined studies showed also in salvage patients, 75% no pads were continent, 70% had minor incontinence. So that is one of the complications which you have, especially after salvage therapy, and are afraid of that. Now, just to conclude what I mentioned before, I think prostate cancer is in the beginning of a multimodular therapy, a sequential therapy, and you can add over the 20-year career of these patients multiple treatment, and usually you would start with the less invasive treatments for the beginning. And they seem to be successful, that you even don't need to change to more radical treatments. Thank you.
Just briefly, in a study I can see where all the subjects would get follow-up biopsies to evaluate their disease status. In practice, what do you tend to use as markers of recurrence after therapy? You've mentioned PSA velocity. Do you have a criterion, a threshold for your PSA velocities, or imaging?
PSA velocity was just for the hemiablation kind of thing. When you look for our study T1, T2, every patient was biopsied, usually after 1 year, with the exception of these which had a higher PSA increase. In our radical prostate HIFU treatment study, the PSA was 0.06 as median. So it was much easier for us from that PSA to judge if anything is going on. That is much more a problem in the hemiablation, because they come down to a PSA of 2-3, which is good and lower than the initial one, but it's very difficult to judge from that point.
And again, even more difficult with focal therapy, right?
Yeah,
Rather than hemi. And that was the question that was brought up earlier. Thank you.